Welcome everyone to the Berkeley Conversations, hosted today by the School of Public Health at the University of California, Berkeley. My name is Nicholas Jewell. I'm Chair of Biostatistics and Epidemiology at the London School of Hygiene and Tropical Medicine, but also Professor of the Graduate School at Berkeley. I'm very happy today to moderate what I think will be an extremely important talk on COVID-19 infection in California farm workers, a population on whom we all depend. I'll make a few remarks, introduce the speakers, and then we'll get going. I should add that you will have an opportunity, if you're listening on Facebook or YouTube, you'll have an opportunity to ask questions. If you type in your questions using the chat feature on either approach, they will be transmitted in real time to me so that I can raise the questions with the speakers at the end. And we're going to try and leave about 15 minutes for questions. I wanted to point out that California is the leading agricultural state in the United States with over $50 billion in agricultural annual revenue. California employs nearly 800,000 agricultural workers. At the same time, Latinos in the United States have been disproportionately impacted by the COVID-19 pandemic and have accounted for a large proportion of COVID-19 infections and deaths. Farm workers, most of whom in California are Latino, are essential workers and ensure the continuity of the nation's food supply. So it's extremely important that we hear today, to my understanding, the first epidemiologic study worldwide that will tell us what's going on with regard to infection in California farm workers, a high risk and vulnerable population. So let me start by introducing our four speakers. We have Dr. Max Cuevas, who's a leading obstetrician gynecologist and the CEO of Clinica de Salud de Valle de Salinas. He worked as a farm worker growing up until he went to medical school, and so has personal experience of the struggles of farm workers. Dr. Ana Maria Mora is a brilliant physician and epidemiologist who has conducted studies on the health of farm workers, both in their native country, Costa Rica, as well as in other countries, including here in the US. Professor Joe Lunard is an extraordinary infectious disease epidemiologist who before COVID worked primarily on respiratory infectious diseases and vaccines. And this year, he has moved to leading many projects on COVID-19 epidemiology in the US as well as in India. And finally, Professor Brenda Eskenazi is an internationally renowned epidemiologist with a long-standing history in the health. It's our long-standing interest in the health of farm workers and their families. She founded the Chamacos study more than 2 decades ago and has followed the health and development of children of farm workers since then. So let me pass the mic over to the speaker, starting with Dr. Cuevas.
Thank you so much, Dr. Jewell. Agriculture is the largest industry in Monterey County. It's known as the salad bowl of the nation, and it employs up to 90,000 farm workers, depending on the season. Up until November 12th, we were one of the counties, along with most other agricultural counties, that was in the purple tier with the widespread transmission of COVID-19 and not meeting the measures for opening up. Now we're joined by almost all other California counties. In Monterey County, as across California, there is a disproportionate burden of COVID infection among Latinos. According to the last census, Latinos represent 59% of the population in Monterey County, but 74% of the cases and 75% of the fatalities. So we asked, why are farm workers getting COVID-19 and how can we prevent illness? Clinica de Salud de Valle de Salinas is a federally qualified health center comprised of 12 clinics throughout Monterey County, serving over 50,000 patients per year and providing about 200,000 patient visits annually. This spring, we received a grant from HRSA to provide testing for COVID-19 to the community. That would include all patients, insured, non-insured, documented, undocumented, symptomatic or asymptomatic, exposed, unexposed. So we tested anyone that wanted to be tested. We have a long-standing partnership with UC Berkeley dating back to about 1998, when UC Berkeley received a large NIH and EPA grant to establish the Center for the Health Assessment of Mothers and Children of the Salinas Valley, otherwise known as Chamacos. And this was a Chamaco study, basically a health assessment of mothers and children here in the valley. Since we began testing in June, we've tested over 16,000 adults, averaging about 120 tests per day. That drastically changed at the beginning of November, when testing doubled, and now more recently actually tripled, with more non-farm workers being tested. On the slide here, we point out the study began July 16th. Since beginning the COVID-19, the test positivity has been higher in the farm worker community than in non-farm workers. The overall positivity rate of farm workers was 22%, and of non-farm workers was almost 17% between June 15th and November 25th. The overall positivity for adults was 19.3%. Positivity rates for farm workers seeking care at our clinic are double what was seen in Monterey County, which is about 11%, and more than 4 times higher than those in the state, which is about 5%. Even those attending our clinics who were not farm workers had very high positivity rates. As an aside, even when we examine those farm workers that were actively working and in the community as part of our community outreach efforts, and they're not seeking care in the clinics, we observed a positivity rate of 7.5%, which is still fairly high compared to the county numbers.
So we decided to, in collaboration with Clinica, researchers at UC Berkeley decided to start a study, as Dr. Cuevas mentioned, on July 16th. We have multiple criteria for participating in the study. One of them was receiving a diagnostic test for the virus at Clinica via or through an OP swab. We were interested in enrolling people who are age 18 or older, who had engaged in farm work in the last 2 weeks, and this criteria was expanded to farm work since March, more recently. We also included people or farm worker women who were not pregnant, and also farm workers who had not received a positive COVID-19 test in the last 2 weeks. As you can see in the bar graph at the bottom, we recruited most of our participants through the clinic at the beginning, but actually more recently, in the last few months, we were able to increase the recruitment through outreach from the clinic, either conducting clinic-based health fairs, visiting housing complexes where farm workers live, or other type of approaches. And our study was approved by the UC Berkeley Protection Office for Human Subjects. Here in this slide, you can see a list of the study procedures. As I mentioned, a requirement was for farm workers to have a PCR test completed by Clinica. So that was part of the study procedures. We also consented them so that we could have access to their PCR test results from Clinica, and also consent them so that we could store their biospecimens in a biorepository for future health studies. They provided us with venous blood samples that we used to measure IgG antibodies against the virus protein. They provided us with saliva samples that we use or will use in the near future to measure other pathogens in upper respiratory tract. We measure farm workers' weight and height to then estimate their body mass index and determine whether they were obese or overweight or normal weight. They also answer a very detailed questionnaire over the phone, and they all received a $50 gift card for participating in our study. Here we're going to share with you our preliminary results. These are data that we collected between July 16, which is when we started our study, and November 25th, I'm sorry. The study data collection ended on November 30th. So we're presenting data of 1,091 study participants. Most of the farm workers that we included in our study were Latino. They were born in Mexico. About half of them had an annual income of less than $25,000. About half of them were male, had a primary education or lower, and were married or living as married. The average age was about 40 years, and the average time in the US was 21 years. Very important to point out is that although most of the farm workers that participated in our study were Spanish speaker, we had an important proportion who spoke indigenous languages and English as well. As we know, there are several medical conditions that increase the risk for severe complications of COVID-19, among them obesity, hypertension, and diabetes. And as you can see in the graph, almost half of our study population were obese, and this was estimated using the weight and height that we measured on the field. About 14% of them were hypertensive, 12% were diabetic, and only a small percentage were current smokers at the time of enrollment. Most of our study participants came from Salinas or lived in Salinas or Greenfield, but they were, as you can see in the map, they lived in different parts of the Salinas Valley. And these larger places where we enrolled our population are indicated by the circles, the dark red circles, as you can see in Salinas and Greenfield. Most of the farm workers in our study worked in the field, but they also worked in a variety of crops. Most of them worked in berries and leafy greens, but we also had an important proportion of farm workers who worked in the fields, who worked in broccoli, grapes, peas, cauliflower, celery, and others. Most of the farm workers in our study lived in multi-generational crowded houses. About 40% of them lived in overcrowded households, and this was defined as more than 2 people sharing a bedroom. About 20% of them lived with unrelated roommates. Almost 40% lived with a child at home who was less than 5 years old. 10% of them had children who went to school or daycare, and that was more recently as the schools opened for a period of time. And almost 40% did not have access to a washer machine. Very, very important is that we found out that 40% of them had no place to shelter if they got sick. And a small percentage reported living with someone who had tested positive for COVID-19, someone who had COVID symptoms, and also a small percentage, which was a pleasant surprise, used public transit or rideshare services. And also a small percentage attended social gatherings. However, as you all know, exposure to those with COVID-19 or symptoms of COVID-19 occurs at work as well, not only in the household and the community. We found out that about 35% of our study participants commuted with non-household members to work. About 10% reported having coworkers who had been quarantined or isolated. About 7% reported working with someone who had COVID-19 symptoms, and about 5% reported working with someone who had tested COVID-19 positive. About a quarter of the study participants worked indoors at least some of the time, and about half of them came within 6 feet of others during their work shifts, not only coworkers, but also customers or clients. And these were all characteristics that were measured within the last 2 weeks before the PCR test was performed or conducted. Something that we didn't expect, but we would define it as a pleasant surprise, is that most farm workers reported that their employers have been implemented workplace COVID-19 prevention measures. And this is good because Monterey County and one of coalitions that was started by Dr. Brenda Eskenazi and Hester Parker have been with other community-based organizations, community members, has been supporting growers in providing all this type of protective equipment to the farm workers. And we found that about 85% of the farm workers had employers who provided them with face coverings, with eye shields, half of them, but also they had employers who were cleaning surfaces. They were providing them with hand sanitizers. They had hand washing stations at work with liquid soap and paper towels. So these were all positive findings in our study. A lot of the farm workers also said that their employees had told them about distancing at work, had told them about the importance of staying at home if they were sick, told them how to protect themselves at work, how to get tested, how to get paid for if they were staying at home while sick. And a smaller percentage of employers were staggering breaks and had brought medical staff into their workplaces to teach farm workers about COVID-19. And however, there are many positive findings, but we also found that only a third of the farm workers had employers who were getting or screening temperature and symptoms before starting work or upon arrival to the workplace. Something that was extremely shocking to us is that 57% of the farm workers enrolled in our study reported working with symptoms of COVID-19. And a similar percentage, 58%, were going to work when they were positive for COVID-19 and they had symptoms. Most of them said that they were going to work because they felt well enough, but about a quarter went to work because they were concerned about losing their job, losing their pay, or because their employer told them to.
So overall in the study, we tested, as was mentioned, 1,091 individuals by the 25th of November. Results are available for this preliminary report on 1,071 of those individuals, so that's what I'll be summarizing here. So of those who were tested in the clinic, we saw about a 19% prevalence of SARS-CoV-2 infection, and those tested in outreach settings who were not seeking care for illness at the time, just members of the community. 7% of them were found to be positive, which is quite consistent with the figure Dr. Cuevas highlighted earlier today of the high positivity in general community and workplace samples of individuals tested by CSVS. Looking also at how this figure broke down for people with and without symptoms, 28% of those who reported having any symptoms that could be related to COVID in a long questionnaire that we provided were found to be positive, whereas 8% of those who reported no symptoms were found to be positive. Looking at the infection prevalence over time, we saw the highest prevalence of infection at around 18% in the month of September, whereas the figure hovered a little bit higher, a little bit lower at around 14% in July and August, and a little bit lower again in October and November at around 10%. Looking over time at the prevalence of antibody evidence of prior infection, we have these results up through October and are processing antibody results now for the month of November. We saw infection prevalence cumulatively rise from around 9% in July to around a level of about 20% in the months of September and October, meaning that roughly 10% of the farm worker population in Salinas Valley seems to have been infected over a relatively short period in the late summer and early fall. As I mentioned earlier, we asked a long and detailed questionnaire about symptoms that people were experiencing to try to characterize the kind of illness that was occurring and how illness symptoms were related to SARS-CoV-2 infection in this population. Among all of those who were found to be positive, we saw that only 58% reported any of these symptoms, which is a sort of long list that includes those that are quite, canonically associated with COVID-19 and others which might be less clearly associated with COVID-19. Looking at specific symptoms in particular that ended up being quite important, there were some like fever, which is a canonical symptom that many would suspect COVID-19 to be a cause of fever during the time that we live in right now. We also saw loss of smell and loss of taste, which are well-known hallmarks of SARS-CoV-2 infection, at least for some patients right now. We saw each of these were associated with very high odds ratios, indicating very high excess prevalence of infection among people who reported these symptoms as compared to people who did not report these symptoms. Likewise, we saw 34-fold and 9-fold higher odds of infection associated with reporting shortness of breath or difficulty breathing. However, what's notable is that each of these symptoms is not very prevalent among all of those who were found to be infected. So individually, fever here as one of the hallmarks of infection is, found in or reported in only a quarter of cases, and even lower numbers here for some of the other characteristic symptoms such as loss of taste and loss of smell. Looking at factors that were predictive of being infected, we saw several things that were notable. Here I am going to be talking about the prevalence of each risk factor or of each exposure in a comparison of people who were found to be negative or positive for SARS-CoV-2 infection. So we saw, for instance, in a comparison of negative and positive test results, that there was a higher proportion of people who spoke indigenous languages among those who tested positive. There was a higher proportion of people who had primary or lower levels of education among those who tested positive, and a small suggestion that there was a higher proportion of people who were not from the city of Salinas, which is the main urban area in this region, among those who tested positive. Looking at factors in the household that might be associated with infection, we did not see very clear signs that overcrowded housing, having children at home, living with unrelated roommates, or attending social gatherings were clearly associated with infection. However, we did see that of those who tested positive, there was a suggestion that a higher proportion were those who did not have a place to shelter if they were sick. But there was a higher proportion among those who tested positive who lived with a household member that had either been quarantined for COVID-19, experienced COVID-19 symptoms, or tested positive for COVID-19. In terms of the workplace, we saw some interesting differences in attributes of individuals who tested positive and negative in this setting as well. A higher proportion of those who tested positive were field workers as compared to workers in other agricultural settings. There was no association with working in leafy greens, which is one of the main agricultural activities in this valley. However, among those who tested positive, a smaller proportion worked in berries than among those who tested negative. We also saw interesting pattern where among those who tested positive, a higher proportion reported that they commuted to work in shared vehicles with non-household members on a day-to-day basis, this being associated with testing positive rather than testing negative, and also that workers who reported that no screening for symptoms or temperature checks were done upon arrival, a higher proportion of those who tested positive were working in settings where no screening was undertaken as compared to what was seen among those who tested negative. Last, looking at potential exposures that occurred in the workplace, we saw a significantly higher proportion of people who tested positive reporting that they had worked with someone who experienced COVID-19 symptoms or was quarantined for COVID-19 in comparison to what was observed among those who tested negative. Last, we have begun some analyses looking at what might have predicted being seropositive or having antibody evidence of prior infection at the time that individuals were enrolled. And so what we see here is that a higher proportion of those who were antibody positive were found to be obese in terms of their body mass index than what was seen among those who tested who were seronegative at the time of enrollment. Similar to our PCR results, we saw that a higher proportion of those who were antibody positive had primary or lower levels of education. A higher proportion of those who were antibody positive lived with a child at home under age 5 in comparison to those who were antibody negative. And then last, we saw in the antibody results also an association where a higher proportion of those who were antibody positive reported living with someone who had been a COVID-19 case during the course of the pandemic. We did not see a clear association with exposure in the workplace to a known COVID-19 case.
So almost all the farm workers considered COVID a real threat, and they were concerned about it. They did not think it was a hoax. Nearly a quarter said that COVID has had extremely negative impact on their lives. And this impact has included symptoms of anxiety and depression and arguing in the household. A significant proportion, a quarter of the farm workers reported that they had a loved one who had been sick with COVID, and about 70 people in our cohort had experienced a loved one who had died. They also had reported having difficulty getting medical care or medication. About 1 in 5 reported difficulty, and a very notable proportion, almost 40%, were of low or very low food security, and reminding us that these are the people that are bringing food to our table. They're answering questions from the USDA, such as, do you run out of food at the end of the week and don't have money to buy more? Or do you cut your meals so that someone else in the household can eat? More than half were unable to pay bills. And among those who traditionally sent money home to usually Mexico, about 3/4 had to send less. So with the introduction of a vaccination, we wanted to know whether farm workers would agree to be vaccinated. And what we found was results that are very similar to a recent Gallup poll of the United States, which showed that in our study that only about half of the farm workers were extremely likely to agree to be vaccinated when the vaccine became available to them. There were 20% who were unsure and 11% who were unlikely to be vaccinated. Midway through the study, we decided to ask, why would you not be extremely likely to get vaccinated? And most of the farm workers, 65%, the major report was the concern about side effects. But not an insignificant number also had a distrust of the US government in terms of the vaccine and the safety of the vaccine. Something that is notable, even though the numbers were very small, is that a number of farm workers were unclear about the purpose of a vaccine. That is, they thought of a vaccine as a treatment for COVID rather than a prevention measure. So as in all epidemiologic studies, there are strengths and limitations. And some of the strengths of this study is that we measured infection, current infection, as well as historic infection, the antibody status. Our sample size is large with over 1,000 participants. And we sampled not only from a clinical setting, but also from the community, from housing. In doing so, we could also characterize less severe infection. We established a large biorepository of blood and saliva of over these 1,000 participants, and that allows us to do future research as well. But there are limitations to our study too. Our sample is not a random sample of the farm worker population in Monterey County, and we did not examine farm workers in other counties in California or in other states or in other countries. As such, we do not know if the picture we observed is generalizable to other locations. As a case in point, as Anna mentioned earlier, there was a huge effort in our county by the grower organizations, the employers, the community-based organizations, the providers, to make and get face coverings for the farm workers very, very early in the pandemic. And as such, you saw that over 85% of the farm workers got face coverings from their employer. That may not be the case in other counties that weren't as proactive, or in other locations that weren't as proactive. We do not know if the effects that we have seen on some of the rare outcomes will hold up. And so we really, even though we had a large sample size, we needed an even larger sample size to look at very rare risk factors. We still have a lot of homework to do. As Anna said, we stopped our study on Monday. We have about another 50 people that will be added to the data that we've presented. So we have to update everything we just showed you. We don't believe that the results will change very much given the small number that we'll be adding. We've also shown to you crude results, meaning just the relationship of each variable at a time and how it's related to infection. What we now need to do is put those variables together and see what comes out. And the reason why that's important is because, for example, we showed that amongst indigenous, there was a higher risk of infection. And we also showed that those who lived outside of Salinas had a higher risk of infection. Well, we know that there are more indigenous speaking population outside of Salinas. So will both variables hold up when we look at them together? We also are going to look at other pathogens in upper respiratory tract as risk factors for SARS-CoV-2 infection. We've received a grant from Pfizer to look at pneumococcus. We are currently investigating similar risk factors in other California agricultural counties. We've started off with Madera County, which has a large farm worker population. And very importantly for any study on COVID right now is we need to follow up the cohort to see what the long-term sequelae are of the PCR positive cases, and we're looking to secure funding for that. So in conclusion, we showed a high positivity rate of 13% of Monterey County farm workers. We show that 42% of PCR positive cases were asymptomatic. We showed that the antibody positivity doubled from July to October, and we're awaiting our results for November, but we expect that they'll be the same at 20% or higher. We are showing that the farm workers reported being vigilant about mask wearing, and they were not gathering socially. What was very disturbing to us was the high proportion of farm workers that were going to work sick, going to work with symptoms. Many expressed that the reason they were going to work was their concern of job or pay loss. And I remind everyone that there was a high proportion of the population that were food insecure. Half of our population had no place to quarantine if they were to become sick. Farm workers reported that employers in Monterey County implemented preventive measures, but most of these employers were not adequately screening their workers before the work began for fever and symptoms. We showed higher rates of infection among indigenous language speakers and those with lower education, commuting to work with non-household members, working in the fields, and whose employers did not adequately screen were all at higher risk. We also see that there's been an impact on the financial and health of the farm workers, and it's been negative. And we report that 48% of farm workers in Monterey County are not extremely likely to get vaccinated. So we have some policy and action recommendations based on our research, based on what we've heard from the farm workers in this community. We believe it's important to develop and implement a multi-pronged, comprehensive, culturally and linguistically appropriate education campaign. As of right now, most of the educational campaigns have to do with telling people what COVID is and how to protect oneself. We believe it's also important to make sure that farm workers know what their benefits are. And that means that we need to target all levels in the agricultural industry, the employers, the supervisors, the farm labor contractors, as well as the farm workers, to make sure that farm workers know what their benefits are, but also that the people that are directly supervising the farm workers are doing due diligence in terms of screening the farm workers before they get onto the fields for symptoms and fever. We believe it's really important to increase rapid PCR testing, and we emphasize rapid because we want immediate contact tracing. We think it's important to bring that testing directly to the community, to the neighborhoods, to the clinics, but also to the fields, and to make sure that it's culturally and linguistically appropriate. We think it's important to provide a support structure that allows for immediate and simple to access wraparound services, including on-the-spot income replacement for those who await test results, who are sick, and also to provide mental and family health services and food support. Again, emphasizing the high levels of food insecurity and the population that cannot wait for a week or two to get replacement income. Also, it's very important that this supplemental income should be allocated for all, documented or undocumented. And we want to appeal, especially as we're getting into the discourse right now, to policymakers to prioritize farm workers for vaccination programs, as well as for rapid PCR testing in order to protect this population, but also to secure the US food supply. These programs must address the misunderstandings of testing and vaccination and the mistrust of the government. All the actions that we are proposing must be developed or supported by respected and trusted sources, and that includes the community-based organizations and the community-based clinics. With that, we would like to thank all our colleagues at UC Berkeley and at CSVS, including the wonderful staff that made this all possible. And to our funders, IGI, the Innovative Genomics Institute on this campus, and Clinica de Salud de Valle de Salinas. And to the sponsors of this webinar, IGI, the Berkeley Food Institute, and SEARCH, the Center for Environmental Research in Children's Health. And most importantly, we would like to have a very special thank you to the farm workers who, as essential workers, have toiled during this pandemic, even while there were wildfires, to put food on our tables. Thank you for your attention. These are our email addresses. Please contact us if you have any additional questions after the question and answer period. And also, we have a white paper that is on our website, search.berkeley.edu, and a 2-page summary. So please refer to that if you'd like any additional information. And with that, I will turn it over to Professor Jewell for question and answer.
Thank you very much, Brenda. It's a terrifically interesting and hugely important study. We've gotten an awful lot of questions. We probably aren't going to get through them all in the next 15 or 20 minutes, but we'll do our best. I'll try to direct the questions to the person who covered that part of the talk, but any of the 4 of you should feel free to unmute yourself and break in. I want to ask a question from Maritza first regarding the measurements of the participants of this. Was there any questions about mental health measures or issues that were directed to the participants? Anna, could you answer that question?
Yes, and Brenda can also add more details. We did administer 2 short instruments to determine or identify symptoms of both anxiety and depression. We also selected a few items. We asked about, for some of the examples, we also asked they were not part of a use or standardized scale, had to do with whether there was more arguing in the household, whether they felt unhappier since the pandemic had started. So in using standardized scales for anxiety and depression will allow us to compare to other populations. For examples, in the Chamaco study, there was a visit that was done recently in July. And so we're able to look at some, give some context to the findings that we bring from this study to other study populations, also in the Monterey County and in other counties in California.
And if I could just add one small thing, and that is we also asked about increased substance use, increased alcohol use, and other kinds of activities like that. We didn't see a notable change in those, though.
Thanks. Brenda, staying with you, was there information there about whether these farm workers in your participants were moving around the state during this period of time, or were they all pretty much stable and living in the same place during this period?
Well, I will answer this, but Dr. Cuevas will also know the answer to this. They are right now, at this moment, actually starting in the beginning of November, if you go to Salinas, the fields are pretty much plowed over. Many of the farm workers are moving to Yuma. And one of the concerns we have is, are they taking the virus with them to Yuma? During the time of our study from July to the end of November, there was less mobility within our population. But now, starting now, and maybe Dr. Cuevas wants to add something to that.
Yeah, during the study period, most of the population is stable here in the Salinas Valley, and the crops, the growing season changes, and so now what we're seeing is people now moving over to parts of the Central Valley here in California, Southern California down in the Coachella Valley, and to Yuma. So the concern is, now you're tracking viruses to other parts of the state and other parts of the country. And then we have to worry about February, when the season starts again and people start coming back. And then we'll have to get ready for that movement of people. But most of the time, people are stable here in the Salinas Valley.
Max, staying with you for a second, have farm workers in California been declared as essential workers by the state?
Yes, they have been, and by the federal government as well. So along with healthcare workers and other food production workers, they've been listed as essential workers because they're vitally important to the economic, social, and health well-being of our nation. So they're in there.
Thank you. Now, Joe, I have a couple of questions maybe in your direction. The first one is, can you say something about the reliability of the different test methods, the PCR and the seropositivity measure that was used?
So yes, the PCR assay that was used as the hologic assay of this, that was contracted through Foundation Laboratories in California, and is a FDA emergency use authorized PCR test that's common in use throughout the country with very high sensitivity and specificity. The IgG assay that we use to measure antibody against the spike protein of SARS-CoV-2 was developed and validated in-house in the Harris lab here at UC Berkeley with validation against a variety of specimen types. So first against truly negative specimens from people who could not plausibly have been SARS-CoV-2 infected with dated specimens from before 2020. So people who were never exposed to SARS-CoV-2, and with positive inputs for validation from both hospitalized patients, as well as, quite importantly, from patients who had mild or completely clinically inapparent infection, which is important, especially for a study like this that looks at a relatively mild spectrum of illness, and for community seroprevalence studies in general, because what's been found in follow-up of cases in the past has been that there is often a lower antibody titer among people who are recovering from clinically inapparent or mild infection. So it was important to validate against that kind of specimen for this study.
Thanks. For those who did show antibody positivity, were you able to measure in some sense, the level of antibody presence or quantity, and able to infer from that when they may have been infected?
What we have from the data is a quantitative measure of antibody concentration. So for certain, that is a continuous measure. Backtracking to a specific time of infection is a little bit difficult because many of the people reported no history of COVID-like symptoms in their answers to a questionnaire. And then in addition, the level of antibody that someone has now, is dependent both on their initial antibody response and also on the waning that's occurred over time since the initial infection. So I would not say that we can confidently say when people were infected based only on the antibody titer at the time that they were enrolled in our study. However, one of the useful things of our study is that since it was conducted over a very long period of time, in the course of the pandemic, at least from July to the very end of November, we actually did see real, changes in the dynamics of infection over time, with the highest rates of new infections occurring in August and September, and sort of over the initial months of the study, and things flattening out over the later part of the study. One of the interesting things that I think should be taken to consideration when we talk about the 20% seroprevalence we're seeing in this setting as of October is that there have been other seroprevalence studies undertaken in California, as well as in the nation at large, and including in the Bay Area, which provide some points of comparison for saying how much infection has occurred among Salinas Valley farm workers, and how does that relate to other populations of the US. And so a contemporaneous study here, led by colleagues in the School of Public Health at Berkeley, looking at East Bay communities, has seen roughly 2% seroprevalence in the far more affluent sample. In a study in the summer in the Mission District of San Francisco, enrolling a largely low-income essential worker population, there was roughly 9% seroprevalence. So there's a consistent message coming out of these high-risk, largely Latino essential worker populations, both in Monterey County in a rural setting and in the urban setting of San Francisco, having far higher seroprevalence in comparison to more affluent communities.
Is there a sense that higher seroprevalence rate you saw was because you were largely recruiting in a clinic setting where people who may have either been feeling some symptoms or concerned that they'd been exposed, so that you would have had a higher fraction of them likely to be positive?
So that's true of the PCR testing, which is why it was important for us to present results that were stratified in several ways, one of which was the people being tested in clinics, where we saw naturally a higher proportion that were PCR positive, and only about 7 or 8% were PCR positive, both among those who had no symptoms, whether enrolled in a clinic or in another setting, and among those who were enrolled in the community, so in completely outreach-based testing. For the antibody results, there is a time that that elapses between when someone is infected and when they mount a robust IgG response. And in fact, in our study, we see no association of the antibody titer with the current PCR positive or PCR negative status, which is consistent with the fact that it does take some time for antibody levels to rise significantly. The results that I presented here in the earlier slides, though, are looking only at those who reported having no symptoms, just to clarify, community seroprevalence, not in the stratum of people seeking care for current illness. However, in our study, I think that there is actually not a very big issue of bias also with antibody results among people currently seeking care either.
And were the PCR tests administered once or twice, or to the same individual?
Yeah, individuals receive one oropharyngeal swab for PCR testing.
Okay, so I'm going to go to Anna now and go back to the measurements and ask if there are plans to do any viral genome sequencing for your positive samples?
So we were reached out by the Chan Zuckerberg BioHub staff who were interested in doing genome sequencing, but due to the way that samples are shipped to Foundation and they're processed, we found out that there were some complications in terms of how to then send the samples to UCSF. We are working, as Brenda mentioned, with the Madera County Health Department, and we're administering a smaller version of this questionnaire that we use in Monterey County based on where we found more, differences between those COVID positive and negatives. But they are sending their samples not only for PCR testing, but also for virus genome sequencing at UCSF at the Chan Zuckerberg BioHub. So they will be able to get those results but for those who are enrolled in the study, we weren't able to get that process established on time.
Thank you. Max, was seasonal flu vaccination coverage assessed in the participants, whether they'd had a flu shot or were planning a flu shot?
Since it was sort of the off season for flu, there wasn't a whole lot of questions on that, but we've also noted that system-wide in our clinics, there have been less and less people coming in for flu vaccination. So it's something we're going to try to catch up on to make sure that the community is covered. But during the study period, there really wasn't anything that was asked about, flu.
If I could add something to that, remember that the flu vaccine isn't going to be introduced to sometime in the fall. And so when it was introduced, Dr. Cuevas and us paired up and we had health fairs so that we could do both the PCR testing and the flu shots, and also give out boxes of food that were donated by the grower shippers and the food bank. So during those times, people did get the flu shot pretty early in the season.
Thank you. Max, staying with you about the slides, or either you or Brenda, is there a way, this is from Kevin on YouTube, is there a way to assess whether the reluctance to get a vaccination is due to, you said it was a lot of them were concerned about side effects. Was that side effect concern a fear that they might not be able to work for a few days, or was it just an inherent fear of side effects?
We didn't get that level of detail, and there was mostly concern about side effects or getting COVID itself from the vaccine.
Okay. Joe, this is a question from Mark on Facebook. You pointed out, I think we were quoting this correctly, that 42% of the positive PCR tests were asymptomatic and asymptomatic individuals. Could you say how much that compared to other viruses like influenza or other respiratory infections?
So I don't know if our study is necessarily the best one to draw a generalizable figure about the prevalence of symptoms among those who are infected, since we had clinic-based enrollment for a large, a substantial proportion of all people who were enrolled in the study. I think if we wanted to answer that question with a high degree of precision, it would be better to enroll people and watch, what happens if and when they do become infected, as opposed to what we do, which was enroll people largely in clinics, many of whom were seeking care. If anything, our study for that reason might overstate the proportion of people who have symptoms when they're infected, at least in this relatively healthy, younger adult, working age kind of population. However, it is a common feature of many respiratory viruses that they can be detected, at least by PCR in low quantities for people who both have and don't have symptoms. The specific comparisons to other seasonal coronaviruses, I don't think are actually all that well established. because they've been understudied for many years until really recently when there's been more interest in light of the ongoing pandemic. However, it is a common feature of influenza as well, and RSV and adenoviruses and many other circulating causes of acute respiratory infection.
Thanks, Brenda. I'm going to ask you a political question that's come in. But again, anyone who feels able to comment on this, and this is about sort of variations between California's treatment of farm workers versus federal treatment, and specifically whether you have any opinions about the political feasibility of a supplemental income program for working populations like this during the pandemic.
I can't speak for other counties or other states, but I would suspect that California has probably some of the best policies for farm workers than any other place in the nation, given that it's a leading agricultural state, and also because of our feeling that we have to preserve the industry and the farm worker. There have been initially supplemental programs through the state to give money to people that were undocumented or documented supplemental income during this period of time. And I know that Dr. Cuevas, maybe you'd like to add something about some of the things that you've been hearing lately too.
Yeah, no, this pandemic, like a lot of others, it brought out a lot of the social disparities that exist in our society. So I think one of the biggest consequences of some of those social disparities is, I have to say, the weirdness that we have seen with the response from the federal government. It's not coordinated. As a result, we see lack of coordination at the state and at the local level. So when it's all said and done, if we're going to mount a complete and adequate response, we have to look at issues of social justice as well as public health, and developing public health plans to take care of people. On social justice, we have to look at populations that are being told you're not going to go to work because you're symptomatic or you tested positive. And generally, it's going to be 10 days to 2 weeks that they're out of work. And if you've got people that are earning, fairly low incomes, and if you chisel away at their income, then you've got some big problems. People can't pay their bills. People can't eat. Mental health issues begin to go up. You begin to see a lot of things starting to come up. So the whole thing of replacing income is huge. And thank God that here in Monterey County, our elected officials are in fact looking at that to launch fairly quickly to when they identify somebody who is symptomatic or is testing positive, some replacement income will be there. But I'm hoping that this new administration that's coming in will take the bull by the horns and try to figure out what kind of a response do we all need to put together to make sure that America is safe.
If I could add something to that, Nick, we obviously need immigration reform in this country. And we also need to accept the fact that 60%, the last estimate that we have, of farm workers in California are probably undocumented. And if we're talking about replacement income, we can't forget the population that is working, that is hidden, that are undocumented, to make sure that they too can stay healthy.
Yeah, very well said. Are there plans to expand the study in any way to the Coachella Valley or Imperial Valley to find similar information there, which are big populations of farm workers there also?
I think we would love to be able to expand the study if we had the money. That would be possible. I think Coachella and Imperial County is extremely important to study because the farm workers there work in Imperial County during the day and then go in the evening to Mexico, and the infection is going back and forth across the border. We really need to be doing a similar study in that county as well. As Anna mentioned, we're also trying to do a a slimmed down version of this study that we just presented in other agricultural counties in California.
Well, we still have a lot of questions. Apologies to those that we aren't able to get to. I just want to finish, given the excitement about the current news about the vaccine, Max. How quickly do you think the vaccine will get to this population, even allowing for the fact that there's this reticence in half of the workers to get vaccinated? But how quickly will they get vaccinated, those who wish to?
Well, I think it's going to be a while yet. There's talk here in Monterey County that the state of California has received about 350,000 doses. And the talk is that, within the next 2 weeks. But now it's a thing of who's first, and essentially who's more important. And, so those first waves of vaccine are, coming down the pipeline. But I think also with conversations with people in Sacramento, that we're probably not expecting bigger shipments of doses until the summer and probably into the fall. So it becomes, okay, so who is going to get vaccinated? And we're proposing that it has to be the essential workers, healthcare, food production, to make sure that our food supplies are secured.
Thank you. Well, thank you, all four of you, for what was a very interesting talk and stimulating conversation. I want to thank the audience for the questions and for their attention. I wish we had more time, but we're going to have to draw this version of the Berkeley Conversations to an end. I wish you well for the rest of the day and the evening, and thank you for attending. This will be recorded, and the School of Public Health will make the recording available. Thank you very much.
Thank you.